Good afternoon, everyone. Thank you for taking time and joining us on the fifth webinar of Smile Train Cleft Lip and Palate series. Over to you, Sheila ma'am.
Good afternoon and welcome. I'd like to welcome everybody to this next webinar, as Shrutika said. And at the outset, I'd like to just introduce myself. I'm Sheila Koyana. I'm the Program Director with Smile Train India. A little bit about our organization. You may be aware, Smile Train is the largest cleft charity in the world. We are working in more than 90 countries and have, in our 22-year journey, we have provided over 1.5 million surgeries globally. And India is one of our largest programs. And we do about, say, 38,000 surgeries annually. And in this journey of 22 years, we have provided over 700,000 cleft surgeries. So that said, we have a unique model that we have in India, that we follow in India and all over the world also. We work with local partner hospitals and doctors where we train them, we equip them and empower them to provide these comprehensive cleft care services to all children born with cleft, so that none of them are left out just because of a lack of awareness or a lack of resources. A little bit that's what is said about our organization. Now I'd like to, at the outset of this webinar, I'd like to introduce Dr. Rishikesh Pai, who's the president of TOG. Thank you very much, sir. Thank you for giving us your time and for this collaboration. I'd also like to talk about a very unique initiative which has been spearheaded by Dr. Pai. It is called Badlav, and it stands on three pillars of Ekikaran, Samanta, and Takniki. Whereby the main aim of this program is to provide healthcare to every woman in our country, so that it leads to their well-being and their betterment of their life. Thank you so much, Dr. Pai, for this wonderful initiative, and I'm sure that under your able guidance, it'll reach new heights. I'd also like to welcome Dr. Madhuri Patel. She is the General Secretary of FOXI. Thank you very much, ma'am, for giving us your time and being here with us together. In this webinar, we have two very eminent speakers. We have Dr. Selvapriya Sarvanan. She is the director at Spring Fertility, Fetocare and Fetogene. She's also a clinical director of the Department of Reproductive and Fetal Medicine at the ND Jayashekharan Hospital. I hope I got that right, Dr. Selvapriya, at Nagarcoil. Thank you very much and welcome. We welcome you. Our second speaker for the day is Dr. Savita. She is the professor and head of Department of Audiology and Speech Language Pathology at SRM Medical College Hospital and Research Center in Chennai. She is a master trainer for cleft speech in India. She is a member of Smile Train's Indian Medical Advisory Council, as well as our Research and Innovation Advisory Council. And as a special note, I would like to say that she is our greatest champion for championing our cause all over our country with our speech services. Thank you, Dr. Savita, for being here with us. And with that, I'd like to hand it over to Dr. Selvapriya.
Thank you so much, madam, for all those kind words and this wonderful initiative. And the TOG people, once again, we are back here with a Smile Train. Long back, surgeons used to come from abroad and they used to operate on all the cleft lip and palate children in Kanyakumari district. So I have a little association with Smile Train, which lasts some 10 years back. And they've been here for 10 days and we've accumulated cases and we've had marathon surgeries, and those patients, those babies, they still come to us and we still see smiles. So it's a wonderful thing that you're doing. And to talk about cleft lip and cleft palate, a facial-maxillary surgeon or an orthodontist, so many people, surgeons are there. But you've chosen me an obstetrician and gynecologist specialized in infertility and fetal medicine. And I think it's the right choice because I'm more with obstetrics and more with fetal medicine. I think we will be the first one to actually diagnose the cleft lip and cleft palate. So what happens is whoever might give the end result, the initial panic situation, it's handled by us, starting from the definition to types to explaining them why this has come and what is this going to do to your baby and how can we help you. Once we leave them or hand over them to the safest hand possible, and once they are also convinced, then only our role stops. And then finally, the good things happen when you all finish doing everything and they come back to us. Thank you so much for, motivating us to continue pregnancy. That's the best part we enjoy, even though we are also forced to read a lot about cleft lip and cleft palate other than the diagnosis. So, and the modalities of treatment, how much ever we tell them, you go to the doctor, they will explain. They still want it from the first person who has diagnosed. And the situation has dramatically changed over the years. Previously, face is the identity of a person. It's our lifelong identity. When a small scar, we are bothered. A small pimple, we are bothered. A little hair here and there, we want to keep it neat and trim. Face is the identity of a human being. And so when you tell the patient that the face is going to be scarred, it takes a lot of effort to actually convince them. Because the medical termination of pregnancy rules in India, as of now, recently it's gone up to 24 weeks, but up to 20 weeks, even if it is a correctable lesion or disorder, the parents have the right to choose if they want to continue the pregnancy or not. So it becomes very tricky. You by heart know that this is easily correctable. Even with people with normal nose and normal lips, when the babies are born later at their teenage, these teens, they go for augmentation. They want to change the shape of their nose, change the shape of their lips and the jaw correction and everything. But when you tell them that intrauterine, there is a small dent in the lip and it can be easily covered, so much pressure comes in the family. They're also in a dilemma. Will there be a scar? That will be a main question. Okay, we will correct it. But if there is a scar, it will not look good. So we try to convince them saying there are so many methods nowadays. It's like how initially you used to be scared of appendix surgeries. And now if somebody is saying appendicectomy is done, nothing. We are trying to make it sound cool. So we don't give a big backup or too much of information to them. We say, this is nothing. When we deliver the information, oh, there's a small dent here, but otherwise everything is normal. This is nothing. It will be easily corrected. It also depends on the attitude. There have been painful situations where, in spite of me telling that this is nothing, we will easily correct it, our surgeons are right under the nose, still they have gone for termination. That's been extremely painful because knowing it's 100% correctable and it will not affect them, we still see terminations. It's very painful. So to go with today's topic, because this is more of how we deal with convincing the patients to come and reach you. The journey is with us. And every 2-3 scans, they will come repeated scans. As it closed, is it becoming bigger? So we have to start preparing them too early. That's the way we can catch them early and treat them early and give them better results. So to start with the conventional modalities, so the cleft lip definition is mainly because of the failure of the maxillary process with nose elevation on the frontal prominence. So the babies are showing it. So it can be partial, incomplete, complete, unilateral, and bilateral. So they are, yes, this is how it is. It can be partial, incomplete, complete, unilateral, or bilateral. So next slide, please. And then we go to the cleft palate. So here it results from failure of fusion of the hard palate, like in the picture, with each other and with the soft palate. Cleft lip also usually occurs along with the cleft palate. So when there's only lip, you can't ignore the palate. When there's a palate, you will always mostly see the lip. So again, that is also of complete and incomplete types. The next slide. So this is the picture where you see a unilateral and the unilateral complete, and you see the bilateral incomplete, and below you see the palates, incomplete cleft palate, unilateral complete lip and palate. So it's all depending on how it goes, like how we label our twins, monozygotic, dizygotic. It's all depending on that. Next one. So when you go to the incidence and etiology, it's 1 in 750 births. And the cleft palate is 1 in 2,500 births. Cleft lip is predominantly seen in the males and cleft palate in females. And one more trick is we will not be able to reveal the gender of the baby while doing the scans. Another common question they ask us and pressurize us is it a girl child? If you tell if it's a girl child, then we don't want. It becomes extremely painful when patients or their parents ask like that. And they're saying, doctor, we cannot allow the child to have a scar, a girl child with a scar. So it takes a lot of patience to explain them this is nothing. And they even tell me if it's a boy, they'll grow a mush. So the scar will not be seen. We don't mind. But if it's a girl, it's going to be seen. I said, don't worry. There are concealers and lipstick. But that cannot be the lifelong solution. It's very painful. But still, the awareness is high. They know the surgeries are free of cost. And the incidence of just terminating the pregnancy because you say there is a cleft lip and palate is definitely coming down. So if you see the causes, mostly it's genetic. So as a fetal medicine consultant, if I see a cleft lip or palate, first I will jump into the genetic reasons behind it. I want to rule out if there are any genetic issues, the trisomies 13, 18, 21, something is there. If there are any associated anomalies, if it's just an isolated cleft lip and palate, I gain my strength to counsel them and convince them. But before that, I have to really make sure there is no other associated problem. So the causes could be also medication taken by the mother, anticonvulsants, chemo drugs, methotrexate, anything for acne medication. These are just vague reasons. It cannot be the main cause, but can be. It can aggravate. So exposure to certain viruses and chemicals, exposure to X-rays. So anything which prevents the timely closure of the palate and lips, which might interfere at that time of embryogenesis, might be a cause. So maternal alcohol abuse and maternal smoking, all these have been found out. So when you go to the pathophysiology, why are we so bothered? Embryological development of the lower lip and nose fuses with 5 major facial prominences. Your entire face angle, everything is going to change. So the lip development, this is a summary and detailed slides are coming later. So the lip development, it starts by the 3rd and 7th week. The palate starts development by 5th to 12th week. So what I would like to say is we do the nuchal translucency scan at 11 plus 6 to 13 plus 6. Many a times in that scan itself, we will be able to see a beautiful premaxillary triangle, which gives us a clue that it's not going to be a major issue on the face. The premaxillary triangle looks intact. So the chances are there can be a lip thing later, but the bones are intact is something we can identify as early as 12 weeks to 14 weeks. But again, that doesn't mean you have to identify everything at 12 to 14. They are all subjective. There are so many things which can hinder the diagnosis of cleft lip and palate, especially when the baby is not in proper position or the size of the maternal abdomen, poor penetration of the ultrasound waves, very thick abdominal wall. And if the liquor is less or low, you cannot see the bony prominences. So that can be a reason why you can fail to diagnose it as early as 12 to 14 weeks. So complete or partial non-union may affect the palatal bone, upper lip, along with the maxilla, premaxilla, and tissues of soft palate. So thereby you get the cleft lip and cleft palate. Next one. So why are we bothered about it? Because obviously it's the face, obviously it's the identity of a person. And we will also have, before correction, during correction, after correction, we will also have a lot of social pressures, people seeing the baby. And even though by heart we know, especially the bilateral and incomplete ones and all, when they see the complete gap here, you should see the agony they give to the parents, the attenders. We will strictly tell them for the first 2-3 months, do not allow any of your relatives to come and see the baby and confuse you. It's a medical thing. After 3 months, we will finish all the things. And when the baby is fine, you start showing it off to your attenders. I clearly tell them before. So what we expect as complications is the feeding problem, the respiratory infection, the ear infection, hearing loss, speech problem, and dental problem. The next one. So the diagnostic evaluation is maternal USG, and after birth, definitely a physical examination. A direct visualization with the flashlight will confirm the diagnosis. You will be just like that able to say, okay, this is the extent of the cleft lip and cleft palate. Next one. So we need multidisciplinary approach, and that is why gynecologists are brought inside, fetal medicine consultants are brought inside, Foxy is inside because they were the first people to diagnose it. Radiologists have to be there. And then immediately after we diagnose, however, we give the pre-counseling and the preliminary information, we have to involve all the future members of the team in advance so that they don't panic. They will know. See, exposing them to the plastic surgeon or the oral surgeon who's going to operate on them later will give them more confidence when they go to the clinic and see more of those patients, and if they see the results which is being displayed, the amount of panic things they undergo will grossly come down. So if you see the healthcare team, we need the plastic surgeons, the otolaryngologist, and the oral surgeon, orthodontist, dentist. All our dentist friends are required for this, and definitely genetist is also included them. That's what I was telling. We are bothered about the trisomy involvement also in the cleft. Next one. So there are so many surgeries which will be required for certain kind of lip, that it requires multiple surgeries till the age of 18, because we all know that the bone development is just not what we see at the time of birth. It has its own potential and growth graph. So everyone's inborn potential is different. So we need to make sure that some of them require corrections up to 18. And the first surgery is between 6 to 12 months. And the second surgery is somewhere between 8 years. And the third is, and the rest of them are done to improve the speech and scars and improve the, the overall look of the face. And then about the dentition role also comes, because something disturbing the palate is definitely going to disturb. So it's a long process, but a lot of confidence has to be given. And this is where Smile Train will be really helpful, because the money part, the taxing part is being taken care, at least partially or however it is there. So that should give them more confidence. And I think in future, we will also be able to find out ways where there will be one-stop solution. It's definitely evolving, and there will be a lot of ways coming up, because the management of cleft, if you see the previous scars on the oldest of old patients, you still see the scar, but the new ones who are being operated right now, we don't even realize that the surgeries have been done. Everything is improving. So we hope there will be more and more advanced solutions for this. Next one. So we have to, the mother and family should be demonstrated the various techniques of feeding the baby, explain to the parents about risk of aspiration. Small bolus should be given from the corner of the mouth, give the baby sufficient time to swallow. That is an entire taxing training of the mothers, because as much as you teach them, they are emotionally lost, and we need to also keep an attender close by to them, like a mother or somebody who's responsible, and teach both of them. It's very painful for them to see the baby, however we prepare them, but our job is to convince them, and we will be doing the best. So you have to burp the baby must be given all essential care, including immunization, warmth, hygiene, prevention of infection, and explain about the follow-up to the patients. Next one, please. So we have to go to the embryological background a little bit now, because when you have to diagnose it at an early stage, you should also have a basic knowledge of how the embryological development is. So the phase is actually formed by the fusion of number of embryonic processes, like this. And around the 4th week of intrauterine life, 5 brachial arteries develop at the side of future neck, here, like this. Okay, next. And then if you see the structures, they're very simple. The pink one is the frontonasal process, and the triangles are the mandibular arch, and the one is the pericardium. So the first arch, the mandibular arch, is the one in the center, plays the role in development of the nasomaxillary complex. Next one. So then as you see, that is the one which gets connected first. So with the formation of the nasal pits, the frontonasal, that's the pink part, it gets divided into medial and medial nasal process and 2 lateral nasal process. You can see that easily. So that's how it divides. Next one. So then the development of the palate happens. It begins in the 6th week. So develops from the primary palate and from the medial nasal process, and secondary palate from the maxillary process. Next. So, and then the palate is formed by the contribution of maxillary process. The palatal shells give off my maxillary process, and it gives rise to premaxillary region. So we start having it all coming into shape by 9th week, 10th week. 10. Next one. So the fusion, this is the point we need to take care. Like even in twins, we know at what weeks, if we look into it, we'll be able to find the zygosity like this. So the fusion of the palatal shells, it will begin as early as 8th week and which continues till 12th and 7th week. So I'm not saying it's you can find everything at the 12th week, but yes, you can see a proper premaxillary triangle in the 13 to 14 weeks easily. So initially the palatal shells are covered by epithelial lining, and as they join, the epithelial cells degenerate, the connective tissues will intermingle, resulting in their fusion. Next one. So we have to come to the lip. The lip is even more important. Our patients feel that even if the palate is there, it is inside and it's not seen. But when it comes to the lip, it is so external. That is why we have a section in the ultrasound, which is called the nose, mouth, and lips. We have the premaxillary triangle, which is a must. We need to demo in a target scan. And we have the nose, mouth, and lips section, which is must. So if you're not documenting, or if you're not able to document it, it has to be clearly mentioned. If the baby was not in position, you have to clearly mention it, because sometimes not all babies are going to come and show you the face directly. It is all going to be in prone position. It's going to turn to the left. It's going to turn to the right. And all our measurements are based on perfect angles, the nasal bone, and how is the angle face and its relation to the chin and everything. So if you get a baby perfectly lying down in a sagittal position and showing you off the nasal bone and the chin correlation, you're lucky, but it's not like that all the time. So the lower lip is formed by the fusion of the mandibular process of two sides, and upper lip is derived from the maxillary process. This is from the mandible, this is from the maxilla. So failure of merging between the medial nasal and maxillary process at 5 weeks gestation on one or both sides result in cleft lip. Next one, please. So this is a picture of which part comes from where. But in general, it's not that complicated, because an ultrasound, today's world, a decent ultrasound, high-end ultrasounds with all the 4D facilities and all those advanced probes, electronic probes and everything, it can pick up so easily, but not everybody can have a high-end ultrasound. That is why the criteria have been made simpler, so that the diagnosis accuracy is improved later. So around 18 to 20 weeks, a proper premaxillary triangle showing the nasal bone, two lines, and the perfect shape of the lips, everything can be beautifully demonstrated. Unless and otherwise the patient is too fat. In that case, please mention it in the case sheet that you had difficulty while we were visualizing. Do not assume anything that it could be normal, because we have seen cases where after the delivery only the cleft lip and palate was identified, and it becomes extremely traumatic. Next one. So it occurs in a number of ways. Defective growth can be defective growth, or delayed or total failure of the shells to come to that horizontal position, or lack of contact between the shells, or post-fusion ruptures. It fuses and then it leaves. It's not adequate. So failure of the mesenchymal consolidation. So many other ways. Next. So when it is an isolated cleft palate, it is separate. It's very separate, and it appears to be under strong genetic influence. So you don't see anything externally, but you do see, if you're lucky, when the baby is opening its mouth or trying to swallow, you will be able to find out that the shape in which the liquor occupies the oral cavity is little different. It is not in the regular pattern of mouth to the GIT. So more common in the female babies. So severity from mild notching of tip of uvula to cleft extending to the soft palate, and usually associated with certain syndromes. Next one. So again, the etiology, mainly it's heredity. Family history is about 12 to 20% of the cases, and there are certain genetic links which are associated, the transforming growth factor beta, and the genes that have been identified as major role in the development of cleft lip and cleft palate. Generally, if it is a isolated cleft lip or cleft palate, and if we do our regular screenings in the month of 3rd month, we do the double marker screening, and we somehow make sure that there is no major trisomies involved in that. But it is only for trisomies we are screening. There are 101, 1001 other syndromes which are involved, but the commonest ones are the ones we are usually screening. So it has to be kept in mind. Next one. So again, they take a lot of environmental causes. That is the womb environment, the external environment, the nutrition, that is the micronutrient and folic acid deficiencies, and the drugs, like I mentioned, the anticonvulsants and all those methotrexate and everything. So micronutrient deficiency, folic acid deficiency, it also plays a role, like how the neural tube, along with the neural tube defects, the facial clefts are also associated with folic acid deficiency. And certain drugs, like we mentioned, the anti-abortifacient drug methotrexate, anti-emetics, anti-epileptics, thalidomide, dioxin, retinoic acid, maternal alcohol, smoking, these all have been found to have a close relation. Next one. Shrutika, next one. So now we have to go to the infections there, because these are the things we have to brush up, because patients are going to ask you, why am I getting this? They want a reason. When some assault has happened to them or their baby, they want a reason. So they want to know whether it is because of this or that. And so this is the reason we need to know the etiology in detail. So rubella virus, cortisone, and methotrexate and Valium in the syphilis, toxoplasmosis, and embryos exposed to maternal smoking have increased risk of having cleft. So we have to remember the rubella. So the predisposing factors, again, the increased maternal age, women who conceive late have increased risk of having offsprings with clefts. And racial, that is the Mongolians, they have the greatest increase of clefts. And blood supply, any factor that reduces blood supply to the nasomaxillary is, sorry. So let's go into the diagnostic considerations, which is my area of interest. That is the ultrasonography, and the 3D, 4D enables diagnosis, the cleft lip, especially in the third trimester. That's very advanced. Now we will talk about the early diagnosis. Next one. So I want to show few notes and few pictures. So in the lips, how do we see? I told you that we will be seeing the nose, mouth section and the lips. So in the anterior coronal view, that is, we have to put the probe in front of the baby's face so that we will be able to see the premaxillary triangle and the lip. I will be showing the section. So in the anterior coronal view, the nose and the lips are identified. So in the mid-coronal view, the premaxillary triangle, that is here. You come a little bit above, then you will see the mid-coronal view, the premaxillary triangle, and it is formed by the two nasal bones as identified as the two sides of the triangle, and the premaxilla as the base of the triangle. So this is the premaxilla and these are the nasal. So the complete triangle ensures that there is no cleft hard palate. So it's as easy as that. If you are able to see a beautiful triangle, then you can be assured that there is no cleft hard palate. Next one. So I'm showing you, this is the 12 weeks. I mean, the 13, I mentioned you about the third month scan. Look at that, you're able to see the nasal bone. You're able to see the facial angle also. And in the coronal, you're able to see beautifully the premaxillary triangle. So you are given an option in a high-end machine to look at that as early as 12 weeks. And and one more thing, we have to consciously make an effort to see it. We cannot assume. We cannot assume the overall shape. It has to be zoomed. The structures have to be seen. You have to see the nasal bone. You have to see the maxilla, mandible. The three lines have to be visible. And then the angle of the face is also important. It is also equally important, because you will definitely see the chin. Because of the protrusion of the maxilla, you'll be able to see the chin going downwards. So the angle calculation will also help you easily to identify. The next one. So I'm just showing you how it is. This is a perfect thing. This is how we see it in the 12 to 13 weeks. So when you see something like this, for sure, you can be ensured that there is no cleft hard palate. Next one. And advantages of early diagnosis, you always know, it's mainly preparing the patient. First of all, you have to make them convinced, accept the finding, and then prepare them saying that this can be solved and there are people to help. And it's also going to be a painful journey. And we do accept that it's going to be a lot of time inside the hospital with the baby undergoing procedures during the early years. And truly, people understand the pain of subjecting the babies to surgeries at that early age, and organizations like the Smile Train can be of a big help in such situations, because at least we will reduce the trauma or the package of the money they're going to be paying. And if it's the right case, right diagnosis, this is definitely helpful. So the advantages is definitely time for the parent education on management of the baby to be born. Because again, I have a case where I convinced convinced them. They really took all the classes and everything, and they were not able to feed the baby properly, and the baby did go for a aspiration, and it passed away. And the journey was a very tedious journey. In the after 40 days, they came up to us saying that they lost the baby and all that. So it's also extremely important to give them more. You can't just send them home. It looks easy and it will look as though they've understood. But I have one patient where she listened to everything what we said, and still she lost the baby because the feeding habits were not, probably some mishap would have happened, but we cannot talk about it at all. Accidentally, they would have used the wrong technique or something, or they wouldn't have identified the baby who was stressing itself out. So it actually allows the psychological preparation of the parents and allow them to have realistic expectations, and it gives opportunity to investigate the presence of other chromosomal abnormalities, and gives parents the choice of continuing the pregnancy. Next one. So it helps in getting prepared for the neonatal feeding and care and opportunity for fetal surgeries. So I think I've spoken a lot about this. There are a few images. Can you just show those images? Because the repair, I'm not the right person to talk about the repair. So look at this. See, this is how we see the nose and lip. You can see the nostrils also, the openings in the nose you can see. And you can also see the lips, the upper lip, which is just like two buds and everything compared to a normal lip. So this is one picture. Next one. And see, if you see the sagittal view, like how the baby is lying on a cradle, you cannot see the facial features, the nose and everything, the upper lip and lower lip and the chin. Some distortion is there, and you can see all the water around the baby just going inside and occupying the space, whatever is available there. Next one. So this is a general picture, what I've already shown. Next one. Yeah, I wanted to finish up with something normal, because see, you can beautifully see the upper lip, you can see the lower lip, you can see the nose. This ensures there is no cleft lip. The other picture I showed you, where the triangle is seen, that is the one which will ensure there is no cleft, hard palate cleft. So there are simple ways to diagnose it earlier. Again, if it's not diagnosed earlier also, there should be something from the sonologist side which gives you a reason why they were not able to identify it. Because many times, if you hand over a cleft baby to the patients, it's not going to end up that easily for you. So it becomes a pressure that it's one of the most commonest and easiest things that can be picked up in ultrasound, and yet you are not able to pick up, and it creates a lot of havoc. So usually we are very conscious during the target scan. We make sure nothing in the face is abnormal. We even see the orbits, the lens, the distance between the lens, and we see the facial angle. We make sure we see the nose, nasal bone, upper lip, lower lip, chin and everything, and also in the sagittal, and preferably we'll take a 4D also. Suppose we don't get any of this, we also mention what kind of difficulty we had during scanning that patient. The baby was not in position, the liquor was less, and the mother was too obese, so we couldn't see it. But in the repeat scan, we would like to see it again. You have to mention all that, because cleft lip is something, if you miss the diagnosis, it's not going to be an easy walk away for you. So I think as an obstetrician, being the first person to handle a baby with cleft lip and cleft palate, and being put in a place where we are the ones who have to actually give them hope and light and then direct to you, adds more weightage to an organization like ours being collaborating with the Smile Train. And we hope that this bridging the gap will help more and more patients who are having these kind of babies with facial deformities to come forward and accept the fact that it is correctable, and this should not be the reason to actually terminate the pregnancy. So thank you, TOG, and thank you, madam, and thank you, Pai sir and Madhuri Patel, madam, for giving this opportunity on the TOG platform. Subbu and team, thank you so much. And yes, do we have any questions now?
Thank you so much for the wonderful session, ma'am. So we have a question from Dr. Aishwarya Mathai from Bangalore. The question is, what do you think are the ethical implications of antenatal diagnostic testing?
antenatal diagnostic testing of cleft lip and cleft palate?
Yes, ma'am, of cleft lip and cleft palate.
See, right from the NT scan, you have to start mentioning about the premaxillary triangle. The section is an approved section which has to be present. So you might think a nuchal translucency scan is all about NT, nasal bone, and CRL, DV, no TR, and all that. It is also about documenting a little bit of the face. You have to take the fetal face in the coronal, and you should be able to demonstrate the premaxillary triangle. It is so easy. Unless and otherwise, as I mentioned, if it's a very poor penetration case, extremely thick abdominal wall, and you're not able to. So as early as 12 weeks, you have to start documenting the premaxillary triangle, and the nascent bone which you measure is also going to support you to be safe on the side of diagnosis of cleft lip. And then when you come to your routine 20-week anomaly scan, there is no excuse. The facial angle, the nasal bone, the tip of nasal bone, both the lips, the nostrils, and maxilla, mandible, everything have to be clearly visualized. By doing that, the chances of missing a cleft lip or palate is extremely difficult. Is there any question?
Thank you so much. No, ma'am, that's all. Thank you so much for the wonderful session. Over to you, Savita, ma'am.
Thank you, Dr. Shrutika. Thank you, Sheila, for the wonderful introduction. And thanks to Foxy and Smile Train for this opportunity to be sharing information about a very important topic when we're talking of cleft lip and palate, that is speech problems in individuals with cleft lip and palate. Just quickly take a moment to share my screen. Is my screen visible? Yeah. Okay.
Yes,
Thank you. So I'm going to be touching upon the speech problems in individuals with cleft lip and palate. And speech and language development is actually one of the major concerns in individuals with cleft lip and palate, next to feeding issues and appearance. So I'm going to be taking you through these 5 major topics in this presentation. A quick overview on how speech is produced so that we are able to understand how cleft lip and palate impacts speech and language development. The problems are not just in speech as such. There are problems that we see with regards to communication even before speech emerges in children with cleft lip and palate. So what are those problems? And what are the cleft speech characteristics as such once children have begun speaking well in words and sentences? And what are the essential aspects of parental counseling? Because that has a long role in controlling some of the factors that are possible with regards to speech and language development. So these are the 5 broad topics that I'm going to be touching upon in today's presentation. So we all know that speech production is not something which is a resultant of just one system. It is actually an interaction between multiple systems in the body, starting right from the respiratory system and the laryngeal system. And from there on, the voice is produced and it comes up into the supralaryngeal region. And in the supralaryngeal region, we have predominantly the control of what we call the articulatory system and the resonance system. Now, I'm going to focus predominantly on the supralaryngeal region here because that's the area of concern for us with regards to cleft lip and palate. So when the voice produced from the larynx comes out into the supralaryngeal region, there are 2 major things that happens there. One is we move the oral structures because of which we are capable of producing different speech sounds. And 2, the voice that we produce also gets a unique quality because of the chamber through which the sound is passing through. So the voice is actually passing through the chamber, which is the oral chamber and sometimes the nasal chamber. And because of each one of us having a different set of chamber, because of us having different properties there and different sizes there is a unique quality that gets added to each and everyone's voice. And this is what we call as a resonance of the voice. So these are two major systems that are important when we are talking of speech production. And both these systems gets compromised in individuals with cleft lip and palate. So when we are talking of speech, the first major aspect is these physical structures, which we all know is compromised in individuals with cleft lip and palate. And in addition to these physical structures, one has to bear in mind that speech is also a learned behavior. All of us learn how to speak, which means we can also unlearn how we are producing the speech and make changes in the way speech is produced. Now, this is the basic premise on which speech therapy is working. So in the presence of cleft during the early childhood days or during the early infancy, the child is producing certain error patterns, which continues even after the palate gets repaired in children with cleft lip and palate. So as speech language pathologists, we will play a role in helping them unlearn those errors and replace them with the correct kind of speech production. So we have to keep in mind that there is a combination of the physical structure and the learning factors which play a role when it comes to speech production. Now, why is speech and language affected in children with cleft lip and palate despite repairs happening at an early stage? So just to touch upon this, if you look at the repair of cleft lip and palate, in an ideal scenario, the cleft of the lip is repaired as early as 3 to 4 months of age. And the cleft of the palate is repaired as early as 9 to 10 months of age in an ideal scenario in most of the units. Now, despite a palate being repaired at the age of 9 to 10 years, children with cleft lip and palate can have residual speech defects. They do end up having a lot of problems in their speech, which we will be enumerating in the upcoming slides. Now, why is this problem despite the palate being repaired at an early age? One, what happens is speech production is something for which the foundation is laid in the stages as early as 6 to 9 months of age. That's the age during which children produce what we call as babbling sounds, wherein children are just vocalizing in a playway manner. And the production of sounds during babbling is what is going to lay the foundation for later speech and language development. So when children are beginning to babble, they are still babbling with a cleft in the palate. As a result of that, what happens is their productions are slightly abnormal. They are not able to make the placements within the oral cavity, so they move it to the back of the oral cavity. So sometimes it goes as low as the throat and they produce the sounds from the throat. So what happens is these neuromotor patterns get established, and sometimes these abnormal neuromotor patterns, because of this compensations that they do due to the presence of cleft, continues to persist even after the palate is repaired. So even after palate repair, because they were producing sounds with compensations earlier, they continue to produce that even after the palate is repaired. Sometimes there are residual physical defects even in children with cleft lip and palate, even after the palate is repaired. There can be fistula that we see. Sometimes there are abnormal growth parameters because of which there's not much space for them to move the tongue in the oral cavity. Sometimes there are defects like velopharyngeal dysfunction. All of these contributes to the impaired speech production here. Another important parameter that we are concerned about is the altered mother-child interaction. We know the ordeal that a mom with cleft, a child with cleft has when it comes to feeding their children. So in the early stages, in their process of accepting the condition of the child, dealing with feeding issues, dealing with health issues, dealing with all of these, sometimes what happens is the process of interaction between the mother and child sometimes gets compromised. We've sometimes come across mothers who, when we tell them, just play with your child, mothers are at loss as to how to play with their children or how to even interact with their children. So because the early stages, the mother-child interaction process sometimes gets affected in the mother-child dyad, the process of language development and then later speech production becomes compromised in children with cleft lip and palate. Children with cleft lip and palate are also prone to have fluctuating hearing loss, which further has an impact on speech and language development. So it is not just the correction of the cleft that is important. There are a lot of other parameters around that play a role leading towards affected speech and language development in children with cleft lip and palate. So children start speaking in words and sentences maybe by the age of 18 months or 2 years. They generally begin with the first word by the first year, but they start framing words and word combinations together beyond 18 months. So does that mean a speech pathologist in a child with cleft has no role before that? Definitely not the case. There are things that happen even before speech emerges in children with cleft lip and palate. The first findings, so research findings with regards to early development in children with cleft lip and palate has shown, what I've marked here is the age at which children start producing their first word. The ones in red here are the children with cleft lip and palate, and the blue diamonds here are the typically developing children. You can see there is a very clear delay. If typically developing children begin to use their first words as early as around 12 months, children with cleft start only above the age of 18 months. There is a very clear delay in the onset of first words for children with cleft lip and palate. In addition to that, continued monitoring of their development has shown that even by the age of 30 months, children with cleft lip and palate have significant delays. So if typically developing children have the language age of around 30 months, that's when children with cleft lip and palate have a language age of around 23 months, which means there's a clear 6 months delay with regards to the development of language. So there are delays in language development that is evidenced in children with cleft lip and palate, and we have evidence to show that even till the age of 30 months, they're not catching up. So this is something that we can address in the early stage itself. So the best recommended thing is we address these to parents as early as during the time of palate repair itself, so that we are able to establish normal patterns of mother-child interaction, family-child interaction, and we are able to facilitate the normal language development in the early stages. So in the early stages, if there is a delay in language development, in the later on stages, they do have abnormalities in their speech production. Now, the abnormalities in speech production in children with cleft lip and palate is not something that we can just describe in one word. It's a gamut of problems that we see in children with cleft lip and palate. I've just listed the common ones here, what we typically call as cleft speech characteristics, which can be noticed in majority of children with cleft lip and palate. The first and foremost is the atypical consonant production, or what we call as atypical articulation. So children with cleft lip and palate have difficulty in producing certain speech sounds. So let's look at that, what happens there. Now, when we're talking of speech sound production, all of us know that we produce sounds at varied places in the oral tract. So when I'm saying the sound p, I'm producing it at the level of my lips. When I'm saying k, I'm producing it with the back of my tongue. When I say ha, I'm producing it at the level of the throat. So sounds are produced at different levels in the vocal tract. So in this table, you can see each of my row representing different places at which sounds are produced. Going from the anterior most, which is a bilabial, where both the lips are involved in sound production, to the posterior most place of constriction, which is the throat level, where we produce a glottal sound. Now, individuals with cleft lip and palate have difficulties with the anterior sounds especially. Sometimes not the bilabial so much, but starting right from the alveolar, retroflex, palatal sounds, they have difficulty because there was a cleft in that place, in that region in their childhood. They are not able to move their tongue and make productions in those regions. So what happens is they tend to move them all backward. So one of the common patterns that we see in children with cleft lip and palate is they move it so back to the level of the glottis. So for example, if they have to say the word, let us say tata, which is a word which is used to refer to grandfather in the Tamil language, the tata is produced as which is a constriction that they are making at the level of the glottis, at the level of the vocal folds there. So this is with regards to change in the placement. Apart from place of articulation, speech sounds are produced by modifying the air streams in different manners. These three sounds, that is the stops, fricatives, and the affricates, which includes the sounds of p, b, t, d, t, d, k, g, which are the stop consonants. We have the fricatives, which includes the S group of sounds, that is the s, z, sh, All of these are the S group of sounds. And we have the affricates, which is the ch sound. Now, these three categories of sounds are most difficult for children with cleft lip and palate because these are the categories that require us to manipulate the airstream within the oral cavity. The manipulation of airstream for these sounds is very complex compared to the other sounds. So all of these sounds are affected in children with cleft lip and palate. So the anterior sounds or the sounds produced in the front part of the cavity are difficult. The sounds that require air pressure modulation are difficult for children with cleft lip and palate. So in simple terms, we classify these errors into three categories. One is a developmental error, which we don't have to worry about, which is because those are error patterns that we see even in typically developing children. Children don't begin producing all the speech sounds correctly as soon as they start speaking. We know there are certain sounds like the R sound or sometimes the S sound or sometimes sound combinations like tr and all of those, which they produce with errors as part of the development. But once certain maturity comes in, they are able to produce. So these developmental errors can be seen in children with cleft lip and palate also, and those are not sound error patterns that we need to be worried about. But what we are concerned about are the other group of errors called the obligatory errors and compensatory errors. Now, the obligatory error is an error that we are seeing in a child with cleft because of an existing deficit. Let's say we have a child with cleft presenting with a fistula. A fistula is a hole that occurs in the roof of the mouth even after the palate has been repaired. There's been a breakdown and there is a hole that we see in the roof of the mouth. Now, if there is a hole, air is definitely going to escape through that hole there. So if you want a child with fistula trying to produce sounds typically like ch, sa, ta, they are not going to be able to produce it because you're going to have the air leaking out through the nose. So if they are going to say a sa-si, that's going to sound as sa-si, sa-si, with air being pushed from the nose. Now, these are error patterns which we call as obligatory errors, wherein there is a structural defect which is contributing to an error in the speech production. Now, these kind of defects needs surgical intervention before we correct them through speech therapy. On the other hand, there are certain types of error patterns which are just because of maladaptive learned behaviors. So when the child had cleft as an infant, the child was doing this backing. And even after the palate is repaired, the child continues to produce the backing. So let's say if the child has to, as I demonstrated earlier, if the child has to say tata, tata gets produced as despite the child having a normal palate. Now, these kind of errors where the placement is moving backward, which is very commonly noticed in individuals with cleft lip and palate, those kind of errors are what we call as compensatory errors, and those are errors that has to be corrected through speech therapy. Compensatory articulatory errors are very, very commonly noticed in children with cleft lip and palate, and majority of them, almost 60 to 70% of them, will have these error patterns that has to be corrected in the earlier stages itself. The next parameter of speech that we are concerned about is nasal air emission, which is what I was trying to demonstrate earlier, wherein there is a significant escape of air through the nasal cavity when the sound has to be produced in the oral cavity. So I have to do a sa-si, sa-si, which is a sound that completely involves oral air escape. But children with cleft sometimes produce this with a prominent nasal air escape, which we call as nasal air emission. So the sa-si therefore sounds as sa-si, 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 with air escaping from the nose. Sometimes this is a very prominent audible nasal air emission. Sometimes they are very subtle, not very audible. But if you try to place a paddle under the nose, or if you try to place a dental mirror under the nose, you will see that there will be a fluctuation. I'm sorry, can I just have a moment, please? Yeah, so that is nasal air emission, which we can see in individuals with cleft lip and palate. The third parameter, which we see in individuals with cleft lip and palate, is resonance, which is compromised in individuals with cleft lip and palate. But first of all, what is resonance? So resonance is the quality of speech that is there. Each one of us have a distinct voice quality. Each one of us have a distinct voice with which we can identify people's voices. This is predominantly determined by the size and shape of our oral cavities. One of the major factors that determines how the resonance of a person is sounding is what we call the velopharyngeal port. Now, when air comes through the laryngeal system out into the supralarynx, there is one valve which is like a dam between what we call as the oral cavity and the nasal cavity. Air coming out from the lungs through the laryngeal system actually has the capacity to go into both the oral cavity as well as the nasal cavity. Now, what happens when we speak? We have this thing called the velopharyngeal port, which is a port formed by the velum coming in contact with the posterior pharyngeal wall. So when all of us speak, what needs to happen is the velopharyngeal port has to go up and make a closure against the posterior pharyngeal wall. So when I say any of the oral pressure sounds, when I say pa, pa, ta, ka, sa, sha, for all of these sounds, the velopharyngeal port is going and doing its job of closing against the posterior pharyngeal wall, owing to which air comes out through the oral cavity. Now, what can happen in individuals with cleft lip and palate? In varying percentage of individuals with cleft lip and palate, literature almost says from 5 to 40% of individuals with cleft lip and palate can end up in having a deficit that is called as velopharyngeal dysfunction. Now, when this velopharyngeal dysfunction is present, what happens is the velopharyngeal port is not making a complete contact. So you can see the velopharyngeal port remains open like this, as a result of which air can escape through the nasal tract while the sound is being produced. So when the child says papa, instead of sounding papa, it can sound as papa, papa, where you have the air escaping through the nasal cavity as well. So the quality is not just because of the oral cavity, the quality is also because of air passing through the nasal tract as well, as a result of which sounds very nasal twang. So it feels like there is an increase in the nasal perception of the speech. So papa will sound as mama, or tata will sound as tang tang, wherein there is a nasal opening. I mean, the velopharyngeal port is open and air is escaping, or the sound is escaping through the nasal tract as well. So as a result of this, what can happen is very commonly individuals with cleft lip and palate can have this condition that's called as hypernasal resonance. That is, oral sounds appear to be having a nasal twang to it. So there can be a velopharyngeal dysfunction. Sometimes if there is a fistula, sometimes if there is a faulty learning, sounds can escape through the nasal cavity, giving an excessive nasal resonance for the oral sounds. So hypernasal resonance is what we commonly notice in individuals with cleft lip and palate. Very rarely, if they have enlarged tonsils or enlarged adenoids or things like that, there can be presence of hyponasal resonance, wherein the sound is not allowed to pass through the nasal cavity for even the nasal sounds. So if you look into the consonants, the English consonants, the M, N, and the NG sounds, that is a M, N, Ng. These are sounds where the sound has to naturally resonate through the nasal cavity. But when there is presence of any abnormal enlargements of the adenoids or tonsils, or if there is any polyp in the nasal cavity, because of these things, sometimes it can appear with a hyponasal resonance, wherein your nasal sounds sound denasalized. But what is more common is hypernasal resonance, where the oral sounds are appearing nasalized. So hypernasal resonance is another speech problem that we can very commonly notice in individuals with cleft lip and palate. Very rarely, we may find mixed resonance, where we may see a combination of both of these factors. In addition to the resonance, the other parameter that can be affected in individuals with cleft lip and palate is the laryngeal problems. They can have a dysphonia, or they can present with a hoarse voice, because there is a problem of air leakage because of velopharyngeal dysfunction. They tend to overuse their laryngeal system. And even when they are producing error patterns like the glottal stops, as I told you earlier, there is excessive usage of the laryngeal system when there is glottal stop production as well. So because there is over usage of the laryngeal system, because there is hyperreduction or compensation by the laryngeal system to compensate for the loss of air at the level of velopharynx, they can end up having voice problems and leading to dysphonia at times. So all of these are some of the different types of error patterns that we notice in individuals with cleft lip and palate. When put together, what happens is our ability to understand the speech, or what we call as speech understandability, gets compromised in those with cleft lip and palate. Now, one has to keep in mind that all children with cleft lip and palate need not present all of these symptoms. Because you remember, I told you it's a combination of physical factors and learning factors there. So all these symptoms can be present in varying degrees in children with cleft lip and palate, and all of them need not be compromised in all children as well. Now, having understood the problems that we see in individuals with cleft lip and palate, a very brief note about what needs to be done, and I'm especially focusing on what needs to be done in the early stages alone. I'm not going into the speech therapy completely per se, but some precautions or some steps that can be taken in the early stages. I'm just going to emphasize on that. First and foremost, it's important that we provide support and information regarding communication development to parents. Parents should know what is the age at which they can expect their child to speak the first word, what is the age at which children are expected to use word combinations, to speak in phrases and then in sentences. These aspects of typical language development has to be updated to parents so that they are aware of monitoring their own child's language development. There has to be greater emphasis on normal parent-child interaction. This is very, very important because sometimes if we get this going right, if this parent-child interaction goes on well and fine, there are evidences in literature stating that there are possibilities of even preventing some of the error patterns from occurring. Now, the normal parent-child interaction should be emphasized, and parents should be told to stimulate their children using playway methods to facilitate sound production and early vocabulary development. If we actually go back and if we look into our own parenting styles, most of the languages have a lot of these rhymes which has facilitation or stimulation of different sound production. Like, for example, if you take Malayalam, there is this thing called Kake Kake Kudevide, which is a very nice song which is used, which can be very beautifully used to stimulate the production of the k sound. Likewise, there are a lot of environmental sounds which can be stimulated in the playway manner for children, leading to facilitating the production of different speech sounds. So parents should be taught how to engage with their children in a playway manner, and they should be encouraged to use a lot of vocal play with their children so that they are able to facilitate sound production in the early stages. If it is possible, if parents can be educated, it is even worthwhile going one step forward in order to help parents identify the abnormal productions. So if you can train the parents to identify, listen, this is a glottal production. Your child is producing the sound from the throat. Just model the correct production during those sounds. Do not reinforce any glottal production or any abnormal production. If parents are taught about these simple strategies, it has a long way in facilitating better speech and language development in children. So the early stages, especially when a child is getting admitted for a palate repair, that is the point when we can use for speech language pathologists to come in and provide these counseling as to how to facilitate normal speech and language development in children. So preventing development of error patterns is possible with appropriate parental training and providing early intervention there. If we still miss the boat, the child has gone on to speaking and is producing speech with the error patterns that we described earlier, then providing early intervention for the identified problems helps. Because one has to remember, speech is a behavior. And any behavior which if we try to intervene at an early stage, it can be corrected easily. If the child is going to remain with an maladaptive behavior for a long period of time, correcting that is going to be more difficult. Therefore, speech therapy has its better effects if the intervention is started at an early stage. So one of the important roles as professionals dealing with individuals with cleft lip and palate is we will have to motivate the team and the parent to come in early for the intervention process. So motivate the team for early referral, motivate the parents for availing early intervention services. If we are able to tap into all of these, then we will be able to ensure that children start producing speech normally as early as possible. Ideally, at least by the time a child gets into the kindergarten, or, at least in the mid of the primary school, we should have been able to attain normal speech and language development for these children. So that's the thing. To sum up, children with cleft show delay in the development of language, especially in the development of early words. Articulation and resonance errors are commonly noticed in individuals with cleft lip and palate, and this problem becomes worse if the patient is operated late or inexpertly. Early intervention should include parental empowerment, especially focusing on language development. Correction of the structures is an important prerequisite for correction of deficits. Speech therapy can only correct functional deficits. Speech therapy cannot correct the structure of the patient there. Early the structural intervention, better is the prognosis. Continuous monitoring of the speech development is essential throughout the childhood. Thank you.
Thank you so much, ma'am. That was indeed very informative. So we have a question for you. The question is, how effective are the common treatments in addressing the underlying causes of the speech disorder?
There are specific strategies which are used for correcting cleft lip and palate errors. It's important to use those strategies here. And those strategies are very effective in treating the deficits. And especially if we start treating those deficits at an early age itself, say by 2.5, 3 years onwards, if we are able to work on correcting the speech there, then it works definitely. Some people use strategies like asking the child to work on blowing balloons, blowing out candles, sucking using straws, etc. for improving speech. I would like to reiterate that to everybody here that those strategies are not warranted for improving speech in children with cleft lip and palate. There are many therapists out in the common practice where they use activities of oromotor exercises for improving the speech for children with cleft lip and palate. Now, those patterns are not indicated for children with cleft lip and palate here. But otherwise, other treatment strategies where we work on teaching them the placement cues and teaching them how to modify the airflow for speech production works very well in providing speech intervention.
Thank you, ma'am. There is one more question from Dr. Anju Yohanan from Kerala. The question says, how can individuals with speech disorders work with the speech therapist and the other healthcare providers to improve their communication abilities?
Can you repeat the question, please?
Yeah, sure. The question says, how can individuals with speech disorders work with the speech therapist as well as the other healthcare providers in order to improve their communication abilities?
So if this question is on how can people with speech disorders work to correct their problems, if that is what it is.
Yes, ma'am.
Yeah, so as speech therapists, the focus when we are trying to correct any of the speech error patterns. So the first important thing when we identify a speech error is we have to see whether the speech error is because of a structural defect or is it because of a mislearning. Now, if the defect is because of a structural problem, then the first step there will be to correct the structure. Now, if the defect is because of a learned problem, then speech therapy comes into picture. And while we are providing speech therapy, there are two main things which any speech therapist focuses on. One is identifying what is the error with regards to the placement. So if, let's say, for example, every sound has a particular place of articulation and has a particular manner in which it is supposed to be articulated. That is, it has a particular way in which the airflow is supposed to be modified. So as speech language pathologists, our role during the process of therapy is to give them feedback and clue as to how they can make this placement and airflow modification correct. So people with speech disorders get an understanding of that in speech therapy, and they have to go back and practice on those error patterns. They have to practice the cues and techniques that are being followed in speech therapy. Speech is, as I told you, it's a behavior. So it is not something that can just be corrected with half an hour of speech therapy session or 45 minutes of speech therapy session. Whatever is learned in the speech therapy sessions will have to be practiced back home. There will be practice schedules which are given for individuals with cleft lip and palate, and they have to follow that. This is what we call as a home training. The home training module is very, very important, and people should ensure that they are adequately practicing the home training module. And that is when changes brought about in speech therapy can be long lasting and can be generalized onto conversation. So that is an important thing that people with speech disorders will have to do.
Thank you so much, ma'am. Over to you, Sheila, ma'am.
Thank you, Shritika. Thank you so much, Dr. Savita. That was a wonderful session. And also thank you to Dr. Selvapriya. Thank you for joining us. I know you are not feeling too well, but I hope you do feel well soon if you feel better. Since we're coming to the close of this webinar, I'd like to once again reiterate our support and gratefulness for the collaboration with Foxy. Thank you so much, Dr. Pai, Dr. Patel, and the Science Integra team. Thank you so much for this collaboration, and I'm sure that through these webinars and our collaboration at different levels, we will really reach new heights in this partnership. And we look forward to many such sessions. Thank you so much once again.
Thank you.
Thank you.
Thank you so much, ma'am.